Here's a quick review on important positioning terminology that we'll be using throughout all of our positioning courses. Position versus projection. These two words my students often kind of flip back and forth and mistake on a test. Right? If it's asking you radiographic position, that is specific to the position that the patient's body is in. So supine, prone, recumbent, erect, Trendelenburg, something like that. Okay? When it says projection, this is the path of the central ray. So where the beam is entering and where the beam is exiting is the projection. So here's some examples. So PA, posterior, anterior, the beam enters the posterior part of the body, exits the anterior. AP is the reverse, enters anterior, exit posterior. Axial, it's going longitudinally along the long axis of the body, and tangential is skimming between the body part or surface. Lying down positions, if you see the word recumbent, that simply means the patient is lying down. It's not specifying if they're on their back or their stomach. That's where supine and prone comes in. Supine, on your back looking up at the sun, if you will, supine. Prone, face down on your stomach. Lying down with a tilt will either be your Trendelenburg or your Fowler. So Trendelenburg, head is lower than feet, and Fowler's feet lower than head. Standing up, these are pretty easy, upright or erect. Your patient is vertical. An anterior position means the anterior is touching the board, and a posterior position, posterior against the board. Do not confuse these with projection. Those are different terms. Lateral position. So lateral can be recumbent or it can be upright. The lateral is named by the side closest to the image receptor for position. Okay, so we'll take this first picture here. She's standing up. Her right side is against the wall stand here. So this is a right lateral. The patient lying down on the table here, their left side is against the table. This is a left lateral because it's on the table. The image receptor is under the table, so that's closest to the IR. Okay. In these Bucky trays is where your imaging plate will be. So whatever side of the body is closest to the board, that is the name of the lateral. If it's asking you a lateral projection for an extremity, watch the term projection, right? It's asking you traveling beam. So for this ankle, the beam is entering the medial part, exiting the lateral. So that's a medial lateral. For the wrist or the hand, they're doing a lateral hand here. They're entering the lateral part of the hand, exiting the medial. Oblique positions, these can sometimes be a little confusing, but let's keep it basic. Oblique simply means your patient is not facing straight on, or they're not laying flat on their back. They are turned to a certain degree. Sometimes it's going to be 15-degree turn. Sometimes it's going to be 45. All right, but that oblique simply means they're not straight. Okay, you can have anterior or posterior oblique options. These images here, I'm showing you anterior obliques. And similar to that of a lateral, the anterior oblique is named by whichever part is closer to the board. So our young man here standing up against the wall stand, his right shoulder, the anterior part of his right shoulder is touching the imaging plate. This is a right anterior oblique. Okay, same with this young lady here. She is laying down, but her right side is closest to the table. Remember, the imaging plate is under the table. So again, this is a right anterior oblique. She's just laying down. This image here is showing a left anterior oblique. So the left shoulder is closer and the anterior is touching. So left anterior oblique, right anterior obliques, okay? Whatever is closest to the image receptor. The reverse is the posterior, okay? Again, they can be laying down, they can be upright, but a posterior oblique, part of the back will be touching either left or the right. Okay, she's laying down here. The left side is closer than the right because she's rolled up to a certain degree here. So left posterior oblique. Again, his left posterior part of his body is closer than the right here. So this is an LPO again. And over here, this image is an RPO because the right side, the right posterior, is closer. Decubitus. Decubitus, anytime you see this term, usually match it up with the term horizontal beam. What does that mean? It means your beam isn't coming from the top anymore. The patient most likely couldn't turn into a position that you need, or we're looking for an air fluid level. All right, so the patient's either going to be supine or prone here for these dorsal and ventral decubitus. So dorsal decubitus, and remember the posterior part of the patient also can be referred to as the dorsum. All right, so this is a dorsal decubitus because the back is down, ventral's up. See the beam here is coming across as a horizontal beam. This is a ventral decubitus. The anterior portion is down, horizontal beam, ventral decubitus. There's also lateral decube. And lateral decubitus is named by whichever side is down. So your patient's either going to be AP or PA. It actually doesn't matter. There's going to be a horizontal beam. So remember, anytime you see that term, horizontal beam, it's going to be a decube, okay? This lady right here is laying on her left side, and there's a horizontal beam. This is a left lateral decubitus, okay? We talk about side down for decubitus position. Most of the time, we're looking for either air or fluid levels. So for the abdomen here, we look for free air, and we'll see that on the right side of the abdomen. So we want air to rise, and we want to look at the right. We'll get to that later on in the semester, okay? The position here, he's PA. His right side is down. This is a right lateral decubitus. This is for a chest, and for chest we look for fluid, so we would look side down. But again, we'll get there later in the semester, okay? So if it says your patient's in a lateral position, there's a horizontal beam, your answer is going to be decubitus, okay? And anytime you see decubitus, we're looking for an air fluid level, okay? Projection, remember this is the path of the beam. So where is the beam entering? Where is it exiting? We talked about anterior and AP and PA, okay? So this is your PA, entering PA, exiting anterior, hitting your image receptor. AP, hitting the anterior, exiting posterior image receptor here. This is an axial image here. It's also called an inferior superior because it's entering the inferior part of the shoulder. It's going to exit the superior, but it's going longitudinal along the long axis of the body. This patella image here is a tangential image because the central ray is skimming between the body part or surface. It's trying to skim here, and we're looking right through to this patella. So that's your tangential. Anatomical position. Every position that you'll talk about in radiology is referenced back to this original anterior position or anatomical position where your patient is looking directly at you, palms out, facing front. One thing I'd like you to go back and look over, and this will be back from A and P for you guys, is your body planes. So know your sagittal, mid-sagittal, coronal, mid-coronal, transverse, horizontal, and oblique planes. Basic terminology, right? Anterior, ventral, posterior, dorsal. We went through that a little bit, but just remember anterior can also be termed ventral, posterior can be dorsal. Proximal and distal. These will come into play a lot. You'll hear this terminology, especially in the OR. So proximal is closest to the midpoint of the body. Distal, I always just think it's out closer to the digits. It's out towards my fingers. So see in this picture here, here's proximal, out towards the fingers is distal. So if your surgeon tells you to move more distal and you're doing a humerus, you're going to move down towards the elbow. You're going to move in this direction. If they ask you to move more proximal, you're going to move closer to the midline. Surface landmarks, these you're going to see a lot of over our entire program, and they're going to be on your board exam. So do me a favor, I would make a flashcard or a list of these to practice, and these are a memorization, okay? Memorize the landmark and sort of the level. So where's the mastoid tip? It's at C1. Where is the iliac crest? It's at L4-5. Those, okay, go through those for me. Body habitus. Body habitus can sort of make adjustments on where the anatomy will be found, right? Depending on the shape of the stomach, the location of the gallbladder, you know, those kind of things. So most of the ones you're going to hear are sthenic, or hyposthenic or hypersthenic. So I'd like you to know the difference between these. Okay, those could be a flashcard too. Tube angles, if we're angling our tube towards the head, we're going to be a cephalad angle. So you can see this arrow is coming up towards the head. This one here up towards the head is cephalad. Down towards the feet is a caudal angle, or caudad. You might see both. You might see that in the OR too. They ask you to angle your C-arm, cephalad or caudad. Okay. More terms: internal rotation, external. Well, wherever the part is normally, rotate it out to the outside is external and is internal. Those aren't too hard. For the hand, pronation, supination. The only way I remember this is someone once told me to pretend you're holding a cup of soup, and that is supination with your palm up. So if that helps anybody. Abduction versus adduction. Abduction is away, adduction is towards, and I was always told, think of adduction, you're adding to, ADD, add, bringing in towards the body. Again, if that helps anybody. These were some terms that I just wanted to collect for you too, and I'm sure you saw almost all of these as part of your A&P 1 or 2, but you're going to want to review these terms because you're going to see these a lot over our positioning time together.